One of the biggest risks for people with asthma is in those people whose asthma is not yet diagnosed. So what's the problem? The problem is mainly that people are often being treated for symptoms like coughing or wheezing without a medical diagnosis. So despite having repeated episodes of respiratory symptoms, these episodes are simply treated as one-off events with cough mixtures or antibiotics or inhaler medication. Now, as I've said in previous podcasts, asthma is a chronic ongoing disease and is not an acute one-off illness. And in this podcast, I'll share my thoughts and reasons why I think the use of terms like wheeze or viral wheeze are inappropriate instead of using a term like asthma or possible asthma as a diagnosis in the medical records. Now, before I continue, these podcasts are intended both for people or parents of children with asthma and also for healthcare professionals who manage asthma. So if you find this episode useful, please do share it and click the follow button so you'll be notified each time I publish a new episode. Okay, so what's the main problem if asthma is not diagnosed? And by diagnosis, I mean that the word asthma is not written in the medical records and that the person or parent have not been told of the diagnosis. It's not really rocket science. If a diagnosis is not made, then treatment may be incorrect or inappropriate, and this could lead to repeated hospital admissions, attendances at emergency departments, or at the doctor's surgery. And secondly, if a diagnosis hasn't been made, then chronic treatment won't be prescribed, follow-up appointments will not be offered, self-management education and a self-management plan would not be provided, and in emergencies, the patient or parent may not communicate essential information for the call taker to decide on the urgency of the person's needs. So, is an urgent ambulance needed right now, or can this be delayed? Most importantly, the sooner the diagnosis or provisional diagnosis of asthma is made, the sooner chronic preventive treatment and patient education can start. On the other hand, if someone is treated for recurrent respiratory symptoms without a diagnosis, medication might actually induce harm. For example, this harm might result from repeated short courses of oral corticosteroids because chronic treatment for asthma had not been prescribed to prevent asthma attacks. And also, inappropriate repeated antibiotic treatments may result in resistance to these drugs. Now, when I was a young general practitioner in the early 1980s, I read a research paper in the British Medical Journal. Now, this was by a pediatrician who suggested that asthma was much more common than we thought in the past. In the UK at that time, only 3 in 100 children, that's 3%, were diagnosed with asthma. This pediatrician was suggesting that in fact more than 10 in 100 children, that's 10% of children, had asthma, and that the reason it wasn't being diagnosed was because general practitioners were not doing their job properly. He said that GPs were to blame for asthma being underdiagnosed and undertreated. Sadly, it turns out he was correct. My then trainee GP and I looked through our medical records in the practice and found that children with asthma were consulting the practice on average 17 times with respiratory symptoms, and that it was taking about 6 years from the first time a respiratory symptom was recorded in the records before the word asthma was recorded. Our BMJ paper in 1984 was the first to demonstrate how long asthma was taking to be diagnosed. So not only was the pediatrician correct that we were underdiagnosing asthma in primary care, and as a result we're undertreating asthma in primary care, but we also discovered that it was taking a heck of a long time. Now, respiratory symptoms include coughing, wheezing, difficulty in breathing, and shortness of breath. where wheeze is a whistling noise that comes from the chest, and it's caused by narrowing of the airways, which is caused by inflammation as well as spasm of the muscles around the airways. Now, asthma is characterized by repeated episodes of respiratory symptoms. It's caused by inflammation of the air passages in the lungs, and these air passages are called bronchi, and they're like small tubes. As a result of the inflammation, three things happen. First, there's swelling of the walls of the air passages, or bronchi. Secondly, a small inflammatory cells, mainly white blood cells, collect inside the air passages, blocking them. And third, the walls of the airway tubes become twitchy and irritable, which results in intermittent tightening of the air passage walls. So the result of these three processes is that the airway tubes become narrowed and blocked, and when this happens, it's hard for oxygen to be breathed into the lungs. Now, of course, oxygen keeps us alive, and that's why asthma is so dangerous. By understanding that there are these three processes involved in asthma, which are all caused by inflammation, you'll understand why we now talk about treating asthma with anti-inflammatory drugs, that's inhaled corticosteroids, as the first-line treatment, because that's the drug that damps down this inflammation and deals with all three of those processes. The reliever inhalers that have been prescribed in the past, the salbutamol short-acting beta-agonist bronchodilator drugs, usually in a blue inhaler, only work against the spasm or the tightening of the airways. They don't work against the actual cause of the spasm, the inflammation. And that's why we're now saying it's dangerous to only be treating asthma with those blue reliever inhalers alone. So 40 years ago, we were taking 6 years and 17 consultations with respiratory symptoms to diagnose asthma. And what's happening nowadays, and why am I concerned? The key problem today is that many people, and this relates mainly to children and teenagers, are treated for respiratory symptoms without considering the underlying cause. So, for example, a child may be admitted to hospital with a number of episodes of wheezing that are treated in the hospital, often with drugs that were used for asthma. And that person will then be sent home with a letter to the general practitioner that the child was treated for an episode of viral wheeze. Now, this happens in primary care, of course, and also following treatment of episodes in the emergency departments. Now, wheeze and cough, and also shortness of breath, and also difficulty with breathing, are all symptoms. They are not the cause of the problem. They're the result of the problem. So they are not the diagnosis of a disease. So what's the problem here? The problem is that these symptoms are caused by an underlying disease, which could be lung disease, like asthma, or an infection or pneumonia. It could be caused by heart problems, allergic conditions, anemia, kidney disease, and many other diseases. So when someone consults frequently, that is more than 2 or 3 times in a year with respiratory symptoms, doctors have a clear responsibility to make a provisional or definitive diagnosis of the underlying cause for these repeated episodes of symptoms. It's no good to just treat the symptoms as if this is an acute or a transient illness. The medical record should clearly state a diagnosis rather than just the symptom like wheeze or cough. If asthma is the possible or probable diagnosis, then the medical record or discharge note from hospital or the emergency department, then the word asthma or possible asthma should be entered as the diagnosis. Now, what's the problem with the diagnosis of viral-induced wheeze or viral wheeze? Remember, I said that asthma is caused by inflammation, which is there in the lungs all of the time. So it's a chronic, ongoing disease requiring chronic, ongoing preventive treatment. Now, this disease, asthma, flares up from time to time in response to a reaction or a trigger of some kind. And typical triggers of these asthma flare-ups, which are also called attacks or exacerbations, are virus infections, exercise, like running for example, exposure to dusts or irritant fumes or pollution, like from cigarette smoke or from vaping, or exposure to substances the person is allergic to, like pollens, animals, or foods. So you'll hopefully understand why it is irresponsible for healthcare professionals in patients who have repeated episodes of respiratory symptoms to just treat the symptoms and to just record the symptoms like wheeze for these repeated episodes without a record of why they think these wheezing episodes are happening. Now, where someone may have asthma, it is essential to record a diagnosis or provisional diagnosis, like asthma or possible asthma. This would then provide essential information both for the patient or the parent and also for any healthcare professional who's later consulted by these patients, and that could be in primary or secondary care or in the emergency departments. Of course, as I've alluded to, if someone is having an acute asthma attack, they'll be far better off if they tell the ambulance call taker that they've got asthma and they think they're having an asthma attack than if they say that they've had wheezy bronchitis in the past. The ambulance call taker is not going to respond very well to that as a diagnosis. Now, I do want to mention how asthma is diagnosed, especially now because the new British guideline is currently being circulated for comment, and in my view, an opportunity to improve diagnosis of asthma is being lost as a result of the current update. The problem is that there is no single test for diagnosis of asthma. The diagnosis is a clinical one, starting with a detailed medical history, followed by a trial of treatment, anti-asthma treatment, demonstration of reversible airflow obstruction, and supported by tests for inflammation, which include the FeNO test, which is also known as the fractional exhaled nitric oxide test, and blood eosinophils. Now, I'll repeat that if I didn't say it clearly enough. FeNO and eosinophil blood tests and spirometry are not diagnostic tests for asthma. The first will test for inflammation, and the second will test for airflow obstruction. Now, there are lots of causes of inflammation, and there are lots of causes of airflow obstruction. And these two tests are not diagnostic tests for asthma on their own. Yes, they can support the diagnosis, but they're not diagnostic tests. And so what's the problem? These new draft guidelines insist on a positive test for inflammation, that's FeNO, and or a positive test for reversible airflow obstruction using a spirometer. They don't offer any other options. So if you don't have one of those tests positive, your doctor will not be able to diagnose asthma, and there will probably be an incentive scheme to back this up. Now, in my view, this is dangerous. Firstly, the FeNO test, as I said, is not a diagnostic test for asthma. If your FeNO is high, it does not mean you've got asthma. It means that you've got inflammation. Furthermore, this test result will fluctuate. I mean, if you've got a cold, for example, the test will be high. And if it's positive, it can help in a diagnosis if the history supports it, but it doesn't confirm the diagnosis of asthma. So it cannot be used to exclude an asthma diagnosis, and that's the important bit to remember. A negative FeNO test does not mean the person has not got asthma. And secondly, reversible airflow obstruction is characteristic of asthma, and it can be demonstrated by either using spirometry or peak expiratory flow. Now, the new British guideline only offers spirometry as a test, and that's where the problem lies. In the same case as FeNO, the spirometry or peak flow results might vary. They fluctuate. They'll be normal when the person is well, and therefore these tests for obstruction may need to be repeated a number of times if the person's medical history is suggestive of asthma. But the new guidelines are saying you only need to do a test once, and if that test is negative, then your doctor will be told that you don't have asthma, and that's where the problem lies. Furthermore, spirometry is not widely available. That is, good quality assured spirometry is not widely available. And it's not convenient to do repeated tests using this equipment. You get an appointment sent to have the test done, and it might be on a day when your asthma is 100% controlled, so the test result will be normal. However, as I said, asthma fluctuates. The airflow obstruction will fluctuate. So if your history is suggestive of asthma and the spirometry test is normal, you should have another test done, but it's not available for repeat testing. So that's why peak flow meters are an alternative, and a peak flow diary could be done, which could help your doctor to diagnose your airflow obstruction and to support the medical history, which would help confirm that you've got asthma. Now, peak flow meters are relatively cheap, they can be prescribed, and it's far more convenient to ask someone to do a daily peak flow diary over a few weeks, especially when they've got symptoms, in order to demonstrate reversible airflow obstruction. So sadly and dangerously, in my view, the new British guideline is, if it's not amended urgently, will lead to lower levels of diagnosis because these guideline committees continue to insist on one of these two tests, i.e. abnormal pheno or abnormal spirometry, to enable a doctor to make a diagnosis of asthma. And this is really crazy in my mind, because the diagnosis is not made, the treatment will not be appropriate, and patients might be at risk from repeated episodes of asthma, which could be dangerous episodes, because they've not been diagnosed and not been prescribed chronic preventive treatment. So the key messages from this podcast: first, for people with asthma or parents. If you or your child has needed to seek medical help for respiratory symptoms twice or more in a year, you should ask your doctor what diagnosis has been recorded in your medical records and what diagnosis was recorded in the correspondence from the hospital. If the record simply states the symptoms that you had, that is coughing or wheezing or breathing difficulty, you should ask for a clear diagnosis to be made, for the cause of these episodes to be investigated, and, if necessary, a referral to a specialist might be needed. Now, respiratory symptoms that are provoked by triggers like exercise, sleeping, nighttime, exposure to dusts, pollen, animals, or food might be caused by asthma, so you should mention this to your doctor. Now, for healthcare professionals, the key messages are, firstly, that it is your responsibility, in my view, to consider the underlying cause for current respiratory symptoms and to record a clear diagnosis or provisional diagnosis of asthma if it is justified by the history. And in the case of children, it's important to remember that the commonest chronic respiratory disease causing recurrent respiratory symptoms is asthma. Now, secondly, it's clear that without a diagnosis, the chronic underlying disease will not be appropriately treated or followed up appropriately. And in the case of asthma, there are many examples of people whose deaths could have been prevented by appropriate education and medical management, which cannot happen without a diagnosis recorded in the notes or without informing patients of the diagnosis or the possible diagnosis. The third key message for healthcare professionals is that in emergencies, having a diagnosis immediately creates a pathway for treatment. This starts with the first doctor or paramedic seeing the patient and continues with a post-attack follow-up after an asthma attack and ongoing chronic asthma treatment with inhaled corticosteroids. And finally, for those of you who are doctors, please do stop using symptoms like viral wheeze or viral-associated wheeze as a diagnosis in children presenting more than 2 or 3 times in a year with respiratory symptoms. In my view, this is not safe, it's a block to further treatment, and does not help your patients. And also, please do make more use of peak flow measurements to diagnose reversible airflow obstruction, and also to classify severity of asthma attacks, and together with patient self-management plans.